Thank you. So we move from one structural heart disease to another. And I was asked to talk about this. This title was given to me, LAA Closure After Stroke WATCHMEN, not WATCHMAN. And a couple questions occurred to me. One is, if we're going to go plural, why not watch people? And also, were they really asking me to speak about Alan Moore's seminal mid-1980s revisionist comic book series, or not just about the WATCHMEN device, but by the variety of devices for left atrial appendage occlusion? And I decided to go with that. Those who want to talk about the series meet at the bar at 10 p.m. Here are my disclosures and a brief outline. This is another approach to treating atrial fibrillation, which of course is a pivotal cause of stroke and of disease worldwide. 1% of the U.S. Of the world population, that's 70 million people with atrial fibrillation, and 5% or more stroke per year, not on any therapy with that, so it keeps a lot of us in business. And risk factors that we know, race, diet, alcohol, height, so reishi and tall interventionalists have more risk than others, but most importantly, age, with the incidence doubling with every decade over the age of 50, which means that as the world population is aging, we're seeing a growing epidemic of AFib and AFib-related stroke. AFib's the cause of more than a quarter of all ischemic strokes, and they're more severe strokes than strokes from other causes. And 1/3 of the patients until recently were not known to have AFib prior to their stroke. Till recently, because we are getting new monitoring, we've gone beyond the Jeffrey Holter's monitor from the 1940s. They are in Jeffrey Holter himself on wearing the original 75-pound monitor, to now the Apple iWatch. And you know, the new wearable devices have been validated by the FDA on the basis of these studies that show they detect nearly as well as standard monitoring. This week in the New England Journal of Medicine, the Apple Heart Study published 420,000 individuals monitored were in an Apple Watch for 4 months, and they found that 1 in 200 had unknown AFib, and a third of those were confirmed by patch monitoring triggered by the reading. The rest probably had it, and it just wasn't captured when they happened to wear the patch, because when the patch saw it, the watch saw it 88% of the time, and it led to, they had more strokes if they had this, they had more heart failure if they had unrecognized AFib, and they were treated more often after the recognition with preventive anticoagulation. So we're going to be seeing a lot more AFib very soon. How can we treat it? Of course, anticoagulation is our standby and highly effective for stroke prevention, reducing stroke incidence by 70 to 80%. But some patients, even in the NOAC era, with its greater safety profile, have absolute or relative contraindications to oral anticoagulation, and for whom a non-pharmacologic approach would be desirable if they've had an intracranial hemorrhage in the past, or multiple microbleeds, or recurrent systemic GI bleeds, or they have severe hepatic renal dysfunction affecting drug therapy. They need double antiplatelet therapy for a stent, and we don't want to put them on triple antithrombotics. They are repeatedly non-adherent to medications, or they have a really high CHA2DS2-VASc score, so even though anticoagulation is going to substantially reduce their risk, they'll still have substantial residual risk. All of those are potential candidates for going beyond this forest plot of anticoagulation therapy to a different approach. And here are the variety of non-pharmacologic approaches to managing AFib. They include rhythm-targeted approaches using catheter ablation or surgical maze procedures to get patient back into sinus, and they include, most relevantly for this group, the new SVIN procedure shown here at the bottom, putting 2 filters into both common carotid arteries so that the carotids are protected from emboli coming from the atrium. Just reported this year a double interventional neurologic procedure for stroke prevention being developed. But the main approach that is done most often is left atrial appendage exclusion. Historically, 70 years ago, beginning with surgical treatment of the appendage, and now moving on to the variety of devices that we have, the endovascularly placed devices, the epicardial from the outside devices, and most paradigmatically, the WATCHMEN device as an example of one of these many ways of blocking or filling the hole, from an endovascular approach on the top, swinging through the heart and occluding the appendage, or at the bottom here, the lariat device, epicardially, endocardially looping and sewing shut the appendage, which has the advantage of not having an endothelial exposure of the device, so does not need anticoagulation immediately afterwards, unlike the WATCHMEN device that requires anticoagulation for 45 days or so in standard management. And so patients who have absolute contraindications to anticoagulation better treated perhaps with the lariat device than with the WATCHMEN device. Why is this our target, going after the atrial appendage? The atrial appendage is a really funny organ. It's kind of like the appendix in the GI tract. The appendix exists to keep abdominal surgeons in business, and the left atrial appendage exists to keep stroke neurologists in business. It is a remnant of the primitive atrium that in the 4th week of fetal life disappears, leaves behind this very different tissue, ultrastructurally, physiologically different. Why is it there? What's been suggested that it's a decompression chamber for the left atrium, and it allows it to absorb peak periods of high pressure, and it has more distensibility than standard atrial tissue. It has more atrial natriuretic factor, so it sends out the signals that things are under pressure. And does that mean that if we take it out, we're going to harm the patient? There's some physiologic effects that are expected and occasionally seen. There's certainly reduced atrial compliance and reduced atrial natriuretic factor secretion, but in general, very well tolerated to lose these minor physiologic aspects. The reason to go after it is where most of the clots lie. A variety of transesophageal echo studies shown here showing that when you see thrombi in the left atrium, it's 90% of the time in the left atrial appendage. There's the Willie Keeler, that's where the money is. Let's focus on that part of the atrium. 90% of the clots are coming out of there. And why? Because it's a separate little chamber with very slow flow, so there's stasis, stagnant clotting, and it has all these trabeculations in it, further disrupting flow and leading to clotting. The anatomy is very interesting. It's been described that there are 4 morphologies of the left atrial appendage in the general population. And here you can see the shapes at the bottom. Of course, pathologists have to apply food descriptors to as many of these as possible. So these have been called the cactus shape, the chicken wing shape, the windsock shape, and the cauliflower shape of these appendages. And you can now print these with your 3D printer before your procedure and hand them to your patient. And you can also play around with your device to see how well it will fit and which device to pull from the shelf to fit the particular anatomy of your windsock or your chicken wing. And it's been suggested that which of these you have might affect the risk. In particular, the chicken wing is a single lobe, and all the others are complex multi-lobe structures. The multi-lobe structures have more stagnation and greater risk, and the chicken wing has faster internal flow and less risk. So that's also important in deciding which of these might particularly benefit from closure. Well, what is the evidence we have from treatment? There have been 2 randomized trials, both of the WATCHMEN device, together enrolling 1,100 patients, the PROTECT AF and PREVAIL trials, and then lots of multi-center registries without control arms, at least 15 studies in a recent review with 8,200 patients, including the other closure devices like the amulet and cardiac plug, and including the lariat device. And here's the randomized trial data from the 5-year follow-up. This is a pooled individual patient analysis from the WATCHMEN trial list, looking at the 2 trials, patients randomized 2-to-1 to closure or not, compared with warfarin. These trials started in the warfarin era, and compared with warfarin closure, the hope was to have something that would obviate any need for warfarin. So these trials were done head-to-head against warfarin, and you can see overall the primary endpoint, which was any stroke, any systemic embolism, or any cardiovascular unexplained death, about equal between the 2. There seemed to be a little more ischemic stroke if you had the WATCHMEN, but a lot less hemorrhagic stroke if you had the WATCHMEN. And there was some more bleeding, if non-cerebral bleeding, if you had the WATCHMEN. So pretty good against warfarin. Now, of course, as soon as the studies were done, along came the NOACs, and this was not enough to say, let's make this a frontline treatment versus NOACs, but it looks like a really good alternative for patients who are not anticoagulation eligible. These procedures do have complications. Device-associated thrombosis has been reported in almost 4% across a large series, usually asymptomatic, seen a few weeks out and disappears with continued antithrombotic therapy. Residual leaks from these devices out of the appendage are very frequent, tiny. They not clearly pathogenic, but don't always, you often don't get a complete closure. You get some stumps or residual leaks. And then during the procedure, there is up to 3 to 4% occurrence of device embolization during placement, which can usually be rescued with an immediate percutaneous grab, but very rarely requires a surgical rescue. So we're getting better with these devices. Here's the complication rates through the initial trials and larger series, and as interventionists get more and more experience with this, the event rates are coming down. Final recommendation shown here for tailored application of this in practice, that if you have not a good candidate for anticoagulation, if you're going to surgery, take a surgical approach. If you're not, think about using one of these devices, and which one to use might depend on whether you also want to treat the rhythm consequence of AFib, in which case the lariat, which would seclude ectopic foci arising from the appendage, might be good to choose. And if you can't have anticoagulation at all, think about the lariat or the amulet. But if anticoagulation is an option, then WATCHMEN or amulet are good choices. So with the dance of brain and heart, we can help treat these complicated patients. Thanks very much.